Of course. Thanks for having me. As Carly said, my name is Lynn Kleckner. I'm an occupational therapist, former UND grad, for those in the room who can relate. Yep. So happy to be talking to all of you. And yeah, so I'm an occupational therapist, and currently I'm working for a company called Microtransponder, and we manufacture the device Vivistim, which is what we will talk about today. And my role is as a therapy development specialist, which means that I get to go around and help to build programs that want to use Vivistim, alongside our territory manager, Ryan Iverson, who is also on. But what we do is we go around and help to build programs, implement programs that want to use Vivistim. But my job in particular is really to make sure that the rehab teams that are using this feel like they are going to be really good at it. They're comfortable using it. They're going to get great outcomes. And then I also work to support the patients and stroke survivors as they work to pursue Vivistim as well. Like I said, Ryan Iverson is on the call. He is on the road today, but he is my partner in crime here as we work to bring this. Ryan, I saw you go off mute. Do you want to introduce yourself?
Yeah, for sure. Thanks, Lynn. Hi, everyone. My name is Ryan Iverson. I'm the territory manager. Lynn and I work exclusively in Minnesota, North and South Dakota, and Wisconsin. I'm currently driving back from Madison, so that's why I'm off camera, but certainly excited that you guys are all here to learn a little bit more about Vivistim and anything that we can ever do to help. Please don't hesitate. So thanks, Lynn.
You bet. And also as a part of the team today, we have Nobs, our engineer, who is on. He is our chief medical officer and the brains behind Vivistim. I don't know. I'm going to give him a chance if he wants to introduce himself. Go ahead, Nobs.
Sure. Thank you, Lynn. Yeah, we started the company almost 17 years ago, so it's been a while, all the way from preclinical to clinical. And so I'm just here to, support Lynn and Ryan. If you have any questions, feel free to ask.
Perfect. Thanks, Nobser. All right. So with that, what we were thinking for today is we'll just run through this slide deck, which talks about everything you're going to need to know about Vivistim. And then at the end, we're really excited to be able to host Chuck Lang, who is the occupational therapy rehab manager from Sanford in Fargo. And their program with Vivistim has just completely blasted off. They're doing an awesome job. North Dakota just helped its first Vivistim patient. He just finished and had awesome outcomes. So I'm really excited to be able to have Chuck join us as well towards the end. But I do like to say, if you have questions along the way, please just jump in and ask. I can't necessarily see the chat, but maybe just blurt in and interrupt me unless, Carly, you want to navigate.
I can monitor chat for you, Lynn. No problem. Yeah.
Perfect. Okay, so we'll get started. So the product we have is called Vivistim, and like I said, the company we work for is called Microtransponder. But before I jump in, I like to give just a big overview of what Vivistim is. It's an implantable vagus nerve stimulator that you can use when paired with physical occupational therapy to help improve chronic upper extremity deficits in ischemic stroke survivors. So with that, we will proceed. Okay, so when I briefly mentioned what Vivistim was, a really key phrase I had in there was the term chronic. And we use chronic to help identify patients who are candidates for Vivistim. And that, in our definition, that means individuals who had their stroke at least 6 months ago. And the reason we talk about that 6-month mark is because we want to make sure that they've had the full opportunity to gain that spontaneous neurological recovery that happens in those earlier phases of stroke recovery. I'm sure many of you on here are providers and have seen that, right? They're in the acute care phase. They make kind of that more rapid recovery. Maybe they move to inpatient rehab. And if they're kind of quick on the ball too, they're probably an outpatient, kind of towards that 3 to 6 month mark. And if they continue on, oftentimes that's when we see that plateau, or they kind of enter that chronic phase of their recovery. Maybe where the focus shifts more on management of their symptoms, compensation, and finding new ways to do tasks that are important to them. if they don't get seen, we know that impairments can worsen over time, and their function can continue to deteriorate. And so the reason that we kind of hit that 6-month mark is to rule out that spontaneous time of recovery, identify the plateau, and then that's when we can jump in and offer an option for individuals who are looking for that boost in their therapy. And with that, we know that stroke survivors are left with long-term functional impairments, kind of like I alluded to on that previous slide. We know it's up to 60% are left with upper extremity impairment in those chronic phases of stroke. And then 78% of those individuals are looking for ways to improve. As an OT, I can say these numbers look really good. I might even argue that it's probably higher. People are always looking for new improvements in those upper extremities following stroke. Okay, in terms of, and we'll kind of talk about where we want to fit in as a company and why it's so important. We're really fortunate to be able to offer an option to individuals who are in this chronic phase of stroke. Again, we know that a lot of times people will kind of fall off the radar after they discharge, either from the hospital, from rehab TCUs. Maybe they'll do about an outpatient rehab, but then, you know, we kind of lose them as therapists. And then we know there's that decline of function that can happen that's associated with that. And then with that, right, decreased quality of life, decreased independence, you know, I've seen higher hospitalization rates, things like that. And so that's where we really feel like, you know, we want to fit in and we want to change that narrative. Is we want to say, hey, we have something now. If you're at that chronic phase of stroke, you know, it's not necessarily the end of the line for you anymore. Keep sticking with your therapist. And then now we even have something that can help to boost the efficacy of you coming back into therapy. All right. And so then that's where Vivistim comes in. It's the first FDA-approved vagus nerve stimulator that we can use to treat upper extremity function in chronic stroke survivors. So you can see here, we'll really dive into the therapy. This slide I like to use just to kind of show the components of the device. So this is how the device gets implanted in the patient. They make a little pocket under the patient's collarbone, and this is done by neurosurgery. And then they thread this is like the battery pack that actually sends the stimulations. The stimulations then travel up through this lead, which is tunneled under the skin. And then the actual coils are wrapped around that vagus nerve. And when there's that stimulation that is delivered from the IPG or this device here, then that sends signals into the brain to help it, to basically put it into a hyper-learning state. I have a really nice video that describes this or exactly what's happening in the brain when that happens. So this is a better picture of what that device looks like, or the implantable pulse generator. This is the lead that's wired under the skin or tunneled under the skin. And then these are the parts that are external. So this is a computer. We call it a SAPS, or a stroke application programming software. And then this is the wireless transmitter that plugs into the SAPS. This SAPS is a one-function laptop. It just communicates with that device to send the signals to stimulate the vagus nerve. We can also get some data from the devices, but from a therapist perspective, this is the tool that you would use on the outside to stimulate the device. Stimulations are fired using a clicker, just like a basic clicker you would use to advance through a PowerPoint, for example. And then a patient can also use a magnet to activate the device at home, and I'll talk a little bit more about that on the upcoming slides. I'm going to pause and see if anyone has any questions before we move on to how this actually works in the brain. Okay.
Don't see any in the chat.
Okay, thank you. And we tested this before. I hope you can hear the sound, but this is the video that demonstrates how Vivistim actually works in the brain when the therapist is delivering stimulation, or the patient is doing that with their magnet. Let me know if you can't hear this.
When someone suffers a stroke, some brain cells die, disrupting established neuronal networks. When those disruptions occur, that loss can make it difficult to perform day-to-day activities with the arm and hand. Pairing direct stimulation of the vagus nerve with rehab therapy works to help regain lost motor function in chronic stroke, providing 2 to 3 times the improvement than rehab alone. This novel therapeutic combination, called paired VNS therapy, works by recruiting other neurons to take over the functions previously performed by the damaged neurons. VNS activates the brain's attention system by prompting the release of neuromodulators, acetylcholine, neuroepinephrine, and serotonin. These neuromodulators interact with the motor neurons being activated during rehab, facilitating lasting structural changes. This change results from the activation of cellular proteins that trigger greater recruitment of AMPA receptors to the neuron surface. More receptors result in more potential binding sites, more dendritic spines, and stronger synaptic connections between the neurons being activated by repetitive functional movements. The more repetitive movements are paired with VNS, the more the connections are strengthened, thereby improving the brain's ability to efficiently relearn the impaired motor tasks. In preclinical studies, the stronger connections resulting from paired VNS therapy led to a 3 to 6-fold increase in the number of neurons involved in activating the practice movements to improve motor function. The improvements with paired VNS were maintained or improved over several years. To learn more about how paired VNS works and how it can help you and your patients, contact a Vivistim representative or visit vivistim.com/VNS.
Okay, perfect. So one of the key phrases there, the most important phrase I would say, is the word paired. So vagus nerve stimulation has to be paired with functional tasks or therapy in order for it to be effective. If Vivistim was just implanted in a patient who, this is an extreme example, sat on their couch and did not move their arms, but they tried to fire stimulation, they're not going to get any benefit out of the device. It has to be paired with functional tasks. And that is where therapy comes in. Any questions on how it works? Otherwise, I will just move forward to talking about exactly how the therapy can benefit the patient.
Don't see any in the chat. Anyone want to unmute?
Perfect. So this is how the therapy would work. So the patient, and we'll talk a little bit about the process of, how the patient gets to this point. But just for background right now, we'll jump right into how the therapy works and why pairing is so important. So therapy can happen twofold while utilizing Vivistim. The first amount of therapy that the patient would get after they're implanted with this is a 6-week bolus of therapy where the patient's being seen 3 times a week for 90 minutes every time they go in, typically with an occupational therapist and or a physical therapist, kind of depending on how sites can schedule out rehab times. What happens during these in-clinic sessions, and you can see in this image here, is the patient facilitated by the occupational therapist. The patient is working through functional tasks, like this one is opening a door, or, using that hand in simulated activities, which might be similar to, prepping to open a door. Now, at the key moments of these tasks, the therapist is trained to look for this anyway, but they're going to stimulate the device, perhaps at the pronation or the supination movement, or maybe at the elbow extension or elbow flexion movement, depending on the part that is the most challenging for the patient that they want to work on. The therapist is trained to provide that stimulation to pair it exactly with the key movement that the patient wants to work on. I should rewind and say Vivistim is not firing or stimulating unless someone is stimulating the device. So if it's just sitting there, it's not really doing anything necessarily. It's only firing a device or only stimulating if the therapist is triggering that. So that's how we're able to pair that stimulation in the brain with those functional tasks. During these sessions, we're looking to get about 300 to 500 repetitions out of those upper extremities to make sure that we're getting that high intensity, high repetition sort of approach to therapy. And based off of what we know from neuroplasticity as well, as the tasks need to be salient and also driven by what the patient wants to do or what the patient's functional goals are. the next phase of therapy, or the next component that the therapy can do, it doesn't have to be in isolation of the clinic therapy. This can all be happening at the same time, well, in the clinic and out of the clinic. The patient can take that red magnet that I showed you and swipe it over the device anytime they want to, up to 8 times in 24 hours. And what that happens is it puts the device into a stimulating a pattern where it will send us a stimulation every 10 seconds for 30 minutes at a time. And so as an OT, this is like a dreamland, because patients can go home and go through their ADL routines. They can walk their dog, they can make their breakfast, they can play games with their grandkids using that upper extremity and turn that device on. And as they're doing something that's meaningful to them, they're able to still get that paired therapy in their own context. And again, that can be done 8 times in a 24-hour period, and that's a rolling basis. So these patients, when they get this, they know there's a lot of work to be done on the back end, and then that's where the benefits are seen. So this is an awesome new tool that we're able to use as therapists now to really boost what we're already doing in therapy. So we know that Vivistim is safe and well tolerated for these individuals. I don't know if many of you are familiar with the epilepsy implants, but surgeons have been doing, it's the same type of procedure to implant Vivistim as it is those epilepsy implants. And we know those have been done safely for over 25 years. Some of the side effects, that I might hear from my patients when they're first getting Vivistim turned on, or, the first time they feel a stimulation, really the biggest thing I hear is they feel like they need to swallow or clear their throat, or do a light cough, and those things subside over time. Really, when patients are using this, they don't typically feel it. And for the real go-getters, that really bothers them, and they want me to turn it up so they can feel it. But that's not necessarily the best practice. Where we set it, and we know the sweet spot for where this is effective based off of our studies. Okay. And speaking of our study, so this is our pivotal study, which we use as our foundation. And, years and years of studies went into this, and Navzer is the man to really talk about this in depth. But for now, I'll talk about this study. This is how we know it works on top of all those other studies I'm talking about. So what happened in this study was it was a randomized, sham-controlled, triple-blinded study, so extremely rigorous. And we had 108 stroke survivors who were all implanted with Vivistim. Half of those had the device turned on, and then half did not have the device turned on. And what happened was they did that 6-week therapy routine. The first group who did not have it turned on, they still made improvements. And I should rewind. We measured improvements using the Fugl-Meyer upper extremity assessment in this study, and we continue to use that today commercially. But what we found was we know that therapy works, and that's demonstrated here. These individuals who were in the control group still made improvements. But what ended up happening was the group that had the VNS turned on and did the pairing therapy actually made a 2 to 3 time improvement in their Fugl-Meyer scores compared to the group that did not have it turned on. These individuals then continued to use those magnets over 90 days later. Again, the control group continued to make improvements, as you might expect, just with regular therapy, but the VNS group continued to make even more improvements using the VNS. And then what happened was they ended up turning the control group on, and then they ended up catching up to make those same functional gains in that Fugl-Meyer that the group who had Vivistim turned on initially ultimately made in the end. So with that, we know that the results of this paired therapy, it's consistent across the subgroups, including the age, severity, and time post-stroke. And it didn't matter at what point they turned the device on, they still ended up catching up to make those improvements as measured by that Fugl-Meyer score. What we're learning now too is that these improvements are maintained through 3 years, and we're looking at that 3-year data, and these individuals continue to improve and then also maintain those improvements over time. So super exciting. Okay, and so now's I think the most fun part is looking at how this impacts patient lives. So we talk about Fugl-Meyer scores, and it's very important, obviously, to measure, objective things such as those types of scores, so that, we can track how people are doing. But the stuff that, really hits home, I know for me and for Ryan, and I'm sure Navzer as well, is seeing the improvements that these people actually have in their life. And how that transfers. And so I have a couple of examples here. This is Kathy. You can see she's 69 years old. She had her stroke. She got Vivistim at 3 years past her stroke. And in the beginning, she is a retired school teacher and a grandmother. And before she got Vivistim, you can see her handwriting here on the left side was not legible, not where she wanted it. And then at 3 years post-stroke, she ended up getting implanted. And 2 weeks into her protocol, you can already see that legibility is improving in her hand and her handwriting. It's important to note, too, that this was an entire piece of printer paper. So still very large and not super practical, but still an improvement. 5 weeks into her protocol, you can see that that size is getting better. The legibility continues to improve. And then at that 8-week mark, she is back within regular notebook lines. And I would say she's got what it takes to write a good letter again. So you can see, she said it's been life-changing. And so we're really happy to be able to, find those sorts of results from people. Another one that really kind of gets me is we had a young woman. She was in Minnesota, but she had her baby after she had her stroke, and she was able to pick her son up now 6 years later for the first time after getting Vivistim. So she had not been able to pick him up the way she wanted to for the first 6 years of his life, and finally got this and did her therapy and can pick him up now. And a 6-year-old boy is like 45 pounds. So that's quite the accomplishment for her. And she is just thrilled as well. I did put a couple of videos in here for you all to see kind of some before and afters of how kind of what people can see across the board during their rehab protocols. There is no sound on these. So I'll kind of read them. So this was a gentleman. He was 59 years old. His baseline Fugl-Meyer was a 42. After 6 weeks, he went up to a 53. And he wanted to be able to pick up a cup without spilling. And I see this goal all the time in the clinic when I am working with patients. So you can see his left hand there at the very beginning of his protocol. Pretty cumbersome and slow. Okay, and here he is after that 6 weeks with an actual cup, because we know that that's function driven and realistic to what he's going to see at home. Okay, and you can see a smile there. All right, so improvements there after 6 weeks. This next person, we can see some more fine motor coordination, in-hand manipulation, and kind of translation across those digits are super common things that I will see in the clinic with people. She was 52 years old, had her stroke 2 years ago, and she just wants to be able to use her hand while eating and doing other functional activities. So this was her first session. So they're raising that coin up on a towel, giving a little more textured background, kind of slow and cumbersome. And at the end, she is able to pick it up off of a slippery wood table and then place it into that container over there. And you can see it's much smoother, and she's moving more quickly as well with that hand. All right, so exciting for her. And then the last video I have is just of some more basic grasp and release. And I believe this gentleman was probably getting ready for Halloween. So 63-year-old man, he got implanted 7 years post-stroke, and he had a 9-point improvement on his Fugl-Meyer. And again, he just wants to be able to use both of his hands. So this was his first therapy session with Vivistim. And you can see there that therapist has the clicker in her finger. That's kind of what this would look like in a regular session. Okay. Now he's going for all the candy. So you can see his hand is opening and closing much more effectively now. Pretty smooth. And obviously very big smiles here. So. And what's important about these tasks too is these therapists are using real life items and things that are actually important to the patients, just to really boost that, what we know about neuroplasticity even more. Yes. Okay. All right. So I'm going to continue on here and I'm going to talk a little bit about identifying candidates. So in order to be eligible for Vivistim, they need to be adults, and by FDA standards, that means they're 22 years and older. They need to have had an ischemic stroke. They need to have that chronic upper limb motor deficit. So that means any time past that 6 months with no cap on that. One thing to kind of hit that point home is we did have a lady receive this implant who was 45 years post-stroke, and she even made improvements as well. They need to have moderate to severe upper extremity impairment, which is defined by a Fugelmeyer evaluation, and that score on the Fugelmeyer would need to fall between a 15 and a 55. And then they can't have a history of a bilateral or left vagotomy. They have to have that left vagus nerve. In order to be a candidate, we need to identify those individuals who are willing and able to complete therapy. Someone who's going to be able to have transportation solved for, they're motivated to want to do this large amount of therapy on the back end. They're going to be able to follow through with any training or home programming. They need to have some active movement of wrist and some digits, and that's just to really ensure that they're going to be able to participate in functional tasks in therapy, because it's all about pairing with those functional tasks. They can have spasticity and they can have sensory deficits as long as both, or one or the other, whichever one they have, is well controlled and or the patient is compensating appropriately to be able to use that upper extremity for those rehab tasks. Okay. So what would happen for the pathway is that patients, we start here on the left side, and these are, anybody can identify a Vivistim candidate is kind of the bottom line. And with that, so oftentimes these referrals will come from the rehab teams, inpatient rehab units, PM&R, neurology, you name it. Anybody who touches a stroke survivor is a great identifier of being able to send these candidates forward. I touched on the stroke team there, statewide stroke associations, resource facilitation teams. You all have an amazing ability to reach out to these patients as well, or at least to let them know this exists. And that kind of dabbles too in the community facing side of things. So support groups, YMCAs, rec centers, places, we can go anywhere, and people can usually find or help to connect stroke survivors with this new option in their communities. When someone is identified, we do go through some initial screenings. We have an entire team dedicated at our company who can do this over the phone. And with that, we have nurse educators as well. And with that, I do this as well, and a lot of the TDSs or my colleagues do this as well. We provide a ton of education to these patients on the front end, so they know exactly what this is all about. They feel confident and comfortable moving forward. They feel like they have a trusted partner in getting through this process. I take that very seriously. And then we make sure that we can help to move them through this process smoothly. I always tell them I don't want any surprises along the way, and that the patient is in the driver's seat, and I want to support them however we can through this and provide as much education as possible. And I know I can speak for others in our company as well when they say that, especially our nurse educators too. The next thing, we find out that they're a candidate, they want to move forward, we would send them off to go see an occupational therapist to have that Fugl-Meyer evaluation done, where we can make sure that they fall within that appropriate range to identify their upper extremity function as moderate to severe. So that would put them between that 15 and 55 on that Fugl-Meyer. If the patient passes that assessment, then we send them off to go see a neurosurgeon who actually does the implanting. But first, the neurosurgeon needs to check them out and make sure that they're a good, safe surgical candidate, and then to be able to answer all of those questions that the patient may have from a surgical and medical perspective. After that, I'll talk more about reimbursement, but we do send all of those documents off to our market access team, and I will talk about that on one of these upcoming slides. But long story short, we make sure the patient has prior authorization from their insurance, and then we move them forward to get the implant. They go home and usually rest for about 2 weeks, and then after that, they begin that 6 weeks of therapy, and then continued swiping of their magnet as well. Okay. On this slide, I mostly just like to talk about the reimbursement and the market access team that we do have. So like I said, after they are seen by OT, they're seen by the neurosurgeon, everybody says, yep, you're an awesome candidate. Then we end up getting their all their documentation sent to our market access team, which is a team of phenomenal people who basically fight the insurance companies on the patient's behalf to make sure that they get prior authorization. I will say with Medicare, we do have a pass-through code, which means that with a Medicare patient, we don't need prior authorization. We do still check all their benefits and make sure everything checks out before moving them to surgery. But Medicare patients have good coverage here. Our market access team will take insurance companies all the way to even court hearings and then continue to appeal so that we can get this amazing procedure and amazing therapy provided to our patients. Okay. This just looks at all the people who are involved in helping to build a Vivistim program. I won't spend too long on this one. And then I did see Chuck come on, and I know I went through this a little more quickly. But Chuck, I don't know if you want to get kind of ready to go, but I'm curious if anyone has questions maybe for the next couple minutes specific to Vivistim. And actually before that, I want to talk a little bit, I'm sorry, Carly, I want to tell you guys kind of where we are in North Dakota. So, and maybe Ryan wants to jump in on this as well, but in North Dakota, we have a fantastic program going there at Sanford and Fargo, and that is why Chuck is on today. He's an awesome guy anyway. We'd have him on too, but he's going to talk about his rehab program. And then we are in early stages of working with Essentia in Fargo as well. But I think I might hand it over to, and I will say on Friday, we're headed out to Sanford and Bismarck too. So super excited to be able to partner with Sanford and the other programs there in North Dakota as we work to bring this to your community members. So Chuck, I'm going to hand it over to you and take it away, and thanks for joining us.
All right, so I'll just kind of introduce myself a little bit. My name is Chuck Lang. I am the occupational therapy manager here at Sanford. I've been here for about 13 years. Under my umbrella, I have about 50 therapists that see patients from acute care, inpatient rehab, outpatient neuro, inpatient orthopedics, and inpatient pediatrics. So a little background on our Vivistim kind of journey and how we end up where we are. I would say last summer, early spring, I was doing some online education like most of us do, and I saw some on vagus nerve stimulation. I was very interested in it. I thought it was very new, cutting edge. I was wanted to know more about it, so I did reach out to our leadership VPs on there, kind of saying, does anyone do this in our system? I think it's something we should look at. Like many times, we hear nothing back for a few months, but 6 months later, here I get an invitation for a meeting with the Vivistim reps, and here we are today. Our rehab or our neuro programming that we have here in Fargo We have a 21-bed Carford accredited rehab unit with our specializations in stroke and brain injury. The majority of our rehab therapists are certified brain injury specialists. For an outpatient neuro perspective, we have 7 PTs, 7 OTs, and 5 speech therapists that all offer specifically neuro-based outpatient services on there, specifically to those strokes, brain injuries, not the orthopedic conditions that we're looking at on here. We also offer outpatient in the home for patients who may not qualify for home health services, but it's a hardship to come in the clinic. We'll help see those patients in the FM metro area if it's a hardship to get in. And we've also started doing some telemedicine visits for those patients who live outside the metro who'd be appropriate for our neuro programming. So to kind of talk about early stages for us for developing our Vivistim program here, right away to start out with, we did a lot of internal referrals for there, meaning that we were looking through my therapist group. I kind of asked them, what patients do you have that you would feel that are appropriate for this? And I'll be honest, off the bat, a lot of them said, well, I don't know if I got anybody. I'm not sure if I have any patients who can do that much time, or I'm not even sure who my ischemic strokes are. But what I found is that through conversation and then by helping identify those patients, talking through the therapist, there's a lot more out there than we think. And so the drill down we started doing is we just started looking at what are our patients within the last 6 months that have discharged from our rehab, and then we would move out further saying, well, what patients do we still have that are actively getting therapy with us who might have been 6 months post stroke on there. And then through there, we're just been slowly being able to identify patients who we feel will be good candidates on there. And I'll be honest, I haven't even done a bigger drill down yet using ICD-10 codes to identify the ischemic stroke patients. They're there. I mean, they're in our community. They're functioning. A lot of them are still getting recovery at this point. It was just kind of on us to help identify those. Our first patient we just recently wrapped up with, a real interesting individual, is blue collar worker, worked as a mechanic / painter. His goal and his focus was really, he wanted to be able to cut up deer and he wanted to be able to cut a ribeye. Those are the two things that he was focused in on doing. And we really focused our sessions to what he wanted to do. And I think that's the key with the Vivistim treatments on there is really gearing it towards what your patient's goals are. It's a lot of the repetitive movements on there. So you got to have the patient on board and really self-directed on, I really want to make this progress and this is what I want to do. So for this individual here, we worked on, we started by just grasp and release, figuring out how to be able to grasp the handle on his fork and his knife. We started actually having to build him up with foam and some Coban. And by the end, sessions I observed with him, he was grasping that on his own. We started by even cutting up pieces of foam that were kind of similar to consistency of steak. And I actually talked to him recently. I said, well, how are you doing with cutting up your steak? And he smiled and said, I had a ribeye last night. So this individual was very extremely motivated and was the best possible patient we could have for the first time. I will say that you have to, when you're identifying patients on here, it's very helpful if you can identify patients who are motivated and can get to that therapy. An hour and a half a day for 3 sessions a week. It's a pretty major time commitment for our patients. So if they're having issues with transportation, if they're actively maybe receiving treatment for cancer or anything else, it just might not be the right time for them to commit to coming in to do the Vivistim. But what we're trying to do with there is we're at least getting some scores on these patients, and we're getting them so we can reach out to them and kind of keep track of them down the line and reach out to them again. This individual that we did see, he saw an 11-point Fugl-Meyer increase. So he went from like a 49 to a 60, so like a 23% increase. And it's been phenomenal actually to see the changes in him and his demeanor, mood. Everyone's just excited for him as he's come in on there. Uh, it takes some creativity with your sessions because you have to make sure that you can keep the transponder in direct or line of sight with the patient. So we've kind of gotten creative with some mobile laptop stations that we can kind of bring around with us. We've had some pretty good success of having patients even wear t-shirts with pockets and things in them so we can put the transponder in there. But I think the fear that a lot of therapists had initially was, what am I going to do for an hour and a half with this patient if I'm only working on self-feeding? And we kind of found that the time filled itself. There's so many parts of that task and that skill that we have to look at that the hour and a half was not uh, difficult to fill at all. Um, Things that we've kind of been implementing and trying to follow through on here. So this individual now has graduated from his Vivistim program on there, but we still have continued to see him. And when we bring him in, Lynn might have touched on this before already, but it's the way I think that her and Ryan do a good job of explaining it is it's our therapy sessions on steroids, right? We're providing the same type of functional movements and the same type of activities, but the vagus nerve stimulation just adds another level of that paired vagus nerve stimulation that helps regain that function with them. We've continued on with him. When he comes in now, we do swipe his magnet during those sessions. So we have the device working while we're working in there. We're just not doing the same amount of 90 minutes a day, 3 times a week on there. I believe we've kind of put him down to like even twice a week right now during that. The patient himself, I know that he had some reservations and he was worried about regressing after his Vivistim 6 weeks were up. And we just kind of had purposeful conversations with him to let him know that, as long as you're continuing to use that affected limb, you're swiping your magnet to get the device on, and you're doing those movements, he's going to continue to see those gains. He's going to be able to continue to see carryover of the function that he's regained. So we've really encouraged him to just keep on with his daily activities, but while swiping that device to kind of get that stimulation on there. As far as looking at activities, I've really kind of been stretched to think outside the box a little bit more with our patients. We're really trying to think of, again, those more functional activities. And for some of the younger ones is like, what are their work activities? If it's mechanic work, carpentry, how do we, again, make those tasks functional and meaningful for those patients on there? The response we've had from the community so far has been very good. We've been basically just kind of relying on word of mouth as of now on air and referrals internally. But we're getting a lot more questions, a lot more patients coming to us from the rehab, asking about if they'd be appropriate for it, what are their next steps to get those patients in. We're kind of hoping is quite honestly that there will be eventually more sites that are able to provide this, because we know that it's going to be a hardship for patients that are probably outside of a 1 hour radius to always commit to coming to Fargo for an hour 3 times a week. We would like to be able to have these patients from all over the region be able to kind of see their therapists in their home environments on there. Because again, we find that's probably more meaningful, more functional for those patients on there. So keeping track of orders, some of the things that we like to keep track of on here is we're tracking patients' Fugl-Meyer scores. We are also kind of looking at eventually getting to tracking some of other functional like balance, such as like a time get up and go. Another area I'm looking at is I want to track even the depression scale, because I feel like there's going to be a secondary anecdotal results that are going to be beneficial from this vagus nerve stimulation that's outside of just that upper extremity movement. We should be seeing improvements in their functional balance. If there was a gait disturbance, if there was a higher prevalence of depression on there, I would anticipate it improving, but I need to get the data first. And that's what we're really kind of wanting to put together this first year with our patients is, what are we all gaining in addition to the Fugl-Meyer score? Because the Fugl-Meyer to me is only one adjunct that we're looking at on here. It's the patient's whole, in general, like well-being, holistic approach on there. So that's just kind of a little overview, I guess, of what we are doing for our program on there. Any questions? I guess I'll kind of open it up if you guys have questions for me of what we've seen and challenges or um, questions I can answer for you.
How are the insurance companies authorizing like the extensive therapy and things like that? Or is it still a difficult thing currently?
We have not had any problems with it on there. We bill our sessions the same as we would before. We had to change our plan of care when if we weren't seeing them 2 times a day and we're moving up to 3, we had to change our plan of care. But the insurances really don't dictate the length of your sessions on there. And then really for this program, and Ryan or Lynn can correct me if I'm wrong on here, but when insurance is saying we're going to pay for the device, they're saying they're going to pay for the follow-up therapy afterwards, because the device does no good unless you have the therapy afterwards in the adjunct to have the paired vagus nerve stimulation. It requires that skilled therapist, as silly as it sounds, to hit the button to pair at that time to break down that task through a task analysis to perform those activities.
Yeah. Yeah, you're absolutely right, Chuck. And thanks for speaking from your own experience there. And, to add to that too, when we're looking at getting that prior auth for surgery, our teams are also looking at their rehab benefits and making sure that, they're going to be okay to get that therapy on the back end. So it's being looked at the entire time throughout, scheduling therapy, scheduling surgeries, but also our entire market access team is on that very well too.
Thank you.
Mm-hmm.
I feel like that one of the biggest barriers we may have in North Dakota for this is obviously is access. We're just kind of a rural state, obviously, so getting patients to have access throughout the state to receive the services, I think, are going to be our biggest challenge moving forward. But it's not a difficult program, in my opinion, to get off the ground and moving. What it does, it takes a lot of coordination of services and a lot of good communication. So that's, I would say, is the biggest challenge you may face, of how to have a process in place for when a patient, if therapy feels they're appropriate for this and they score a fecal mire within their range, what's our process for getting them over to neurosurgery? Or if it's neurosurgery that's already had a patient refer to them, what's the process for them making refer to us so we can get that fecal mire score in? That's the challenge I think that facilities will face on there, and the bigger you are, the more challenges you can face with that. But use of Teams, WebEx, we've used all those on there, and we've worked through that, and I feel like we're getting to a point now where I can kind of manage those patients on there and keep track of where they're at. It's just kind of basically moving them along the line so we're not getting held up after their surgery waiting for therapy. We want to get them in, at that 2-week point, minimally, to get their device program, get them started on a home program, but ideally we want to even get them in at that 2 weeks for their 3 times a week for 90 minutes a session.
And I'll attest to that too, Chuck, is you've been one of the key words here too is, if anyone is interested in building Vivistim at their program, and Chuck hit this home and he's been amazing at it, is just communication. And that comes down to the therapy site. So like Chuck in this instance, really communicating openly with Ryan and myself. And then Ryan and I, as we're building these programs, work to help you and your sites establish those workflows, right? Alongside your partnership to say, hey, we have a candidate. How do we get them from point A to point B? I'm making sure the patient is being triaged through appropriately. Ryan's working on the internal side along with, the leaders and surgeons' offices and rehab offices to make sure all that process is set out as well. So, to Chuck's point, there's building on the front end, but I also think I heard you say, Chuck, it's feeling more manageable now, and those workflows are established. And I can speak confidently and tell you all that Ryan and I take that extremely seriously as our job to be able to help you establish strong programs. And you're never going to feel like you're on an island as you're trying to implement this. At least I hope not. Maybe Chuck, I hope you feel that way, but yeah.
No, I can attest to that. So Ryan and Lynn have been with us the entire step of the way, whether it's getting information for a Fugelmeyer, if there's therapists who aren't familiar with the Fugelmeyer and need someone to do one-on-one training or be there for the initial eval, Ryan and Lynn have been there. Whether it's emails, phone calls, uh, I honestly probably have not felt as supported by a representative company as I have with Vivistim on here. They've been great to our patients as well. And some of the stuff, I've done with them is I'm not the expert on it, right? So I'll call patients, I'll talk to them a little bit about it if I think that are appropriate for it. But my next part is like, do you just want someone to give you a call? And I think that's the biggest thing for a lot of them. They just want to talk through it with somebody, understand what the device is, what the process is. It's a little scary, right? Because you're getting this device that you think you're implanting that's going to be permanent on there, and it's going to maybe change the cosmetically the way you look, but it really isn't. I mean, the patients I've seen on there, the implant is very small. It's not noticeable if you have a little meat on your bones. The irritation or what they've told me is it sometimes feels like a little tickle right away, but it's nothing that is really scary or inhibits their daily function.
Yeah. Yeah. And one last thing I'll add too, Chuck, is you were talking about access. Absolutely, we want to make this accessible to everybody in the large state of North Dakota, knowing that there's a lot of folks in those rural areas too. And so we do want to make sure that we can cast a really wide net across many, different sites who can provide this. And that's another place where Chuck has been so helpful too, is he was able to connect us with the rehab team in Bismarck. And we're actually headed out there on Friday to hopefully get that program off the ground too. Again, improving the access for individuals in North Dakota. Individuals can implant in Fargo. We are up and running there with the surgeon, and then go back to their town and do therapy there too, if they're from out of town. So that's also an option as well. But again, to Chuck's point, improving access, and this is where all of you come into play as well, is helping us to find those right places and find those individuals, so that we can help more people.
We did get a question in the chat. She's an OT and an EMT. Just wondering if there are any special considerations for health emergencies like cardiac arrest.
Special considerations. I wonder, I say if they're in cardiac arrest, do that CPR. I mean, if that was the primary question. As far as, like contraindications, things like that, this is compatible with pacemakers. Surgeons consider things like loop recorders, stuff like that. From a therapy perspective, you can use all those standard modalities, like E-stim or FES, Sabo gloves, things like that. We're just making sure that we're not putting the stim right over where the device would go or within a super close proximity to it. Maybe there was more to that question, but I hope
But I'm thinking more like placement of an AED.
Okay, yeah, I wonder, that might be a good question for Navzer if he's still listening on that one, if that would interfere with an AED.
No, I don't think so. We don't see any, whether it's electrical or even surgical interference. There's been a long history of VNS in terms of safety for epilepsy. And so as far as AEDs, I've not come across anything that says it's a safety concern.
Thanks, Navzer.
And I will share one thing we ran
ahead,
into
Chuck.
too is we had a patient, our patient that came in, he did notice that he was a little more short of breath, but he had an underlying diagnosis of COPD, which he was not diagnosed with before. And it sounds like from what we've looked into is that because of the vagus nerve stimulation, it kind of can suppress your central nervous system. So it kind of depressed his breathing a little bit. So he had a little bit of shortness of breath that he did experience. But it sounds like that is, for the most part, resolved after the surgery.
Mm-hmm.
Yeah, Chuck. So I would say in that situation, again, the vagus nerve stimulation parameters that we use for Vivistim is significantly lower than that's been used for epilepsy. It's only 0.8 milliamps per half a second. And we know from a lot of preclinical studies and even clinical studies that the fibers that are activated to cause that kind of a narrowing, you would need a lot of current to cause that kind of narrowing. So in all likelihood, it could have been an exacerbation just from the COPD and the exertion or the task-specific practice itself, rather than the VNS. A quick check you might want to do is to lower the stimulation parameters and see if it persists. In that case, I think it would persist, and then you know that it's probably not VNS, it's something else.
Yeah. Thanks, Nopser.
Mhm.
One other thing I'll add too is we often get questions about MRI, and you can get an MRI if you have this. We just come in and make sure that the device is turned off and that everything is in working order before the patient goes in to get that MRI. But they also get little cards too that they can show to their providers to make sure that this is all well communicated prior to getting that sort of imaging done. Okay. Well, thank you, Chuck. And can you all still see our contact information there on that final slide? Perfect. Good. Before, kind of the last thing I'll say is if you feel like you want to implement Vivistim or have help identifying candidates, or maybe you have someone in mind already, please reach out to myself or Ryan. Chuck, I'm going to hope that's okay if they reach out to you as well. And we can make sure that they, at least get educated about this, or if a site wants to start using it, we are happy to do that as well, and to begin that process. So like I said, please just communicate as much as you want to myself and Ryan, and we'll make sure that we can make this happen for you. It is, as an OT, it's very, very cool and very, very exciting for stroke rehab. There hasn't been anything like this before. And these people are actually getting really good functional results, like picking up their children, for example, or eating a steak in public. I mean, that's the good stuff as a therapist. So yeah, I will leave it with that. And thank you all so much for the time today. And please don't hesitate to reach out. Thanks again to Chuck for coming on as well.
Yes, and I will just echo that too. Thank you all. Yeah, this is a very exciting and heartwarming to see all those videos and hear about the girl picking up her son and all of that. So yeah, we're excited to see it come across North Dakota. So thank you all so much for your time. We appreciate it.
All right.
Okay. Bye.
Thanks, everybody.